how do you even begin to scientifically classify something as complex and as personal as the human mind? For centuries, we've been trying to draw a clear line between what's normal and what we call a disorder. So to really get our heads around this, let's start with a truly shocking experiment.
That's right. This psychologist, David Rosenhan, got together a group of 8 totally mentally sound people, himself included, and gave them this wild mission. Go to a psychiatric hospital and report just one single, completely fake symptom. And here's the kicker. The moment they were admitted, they dropped the act entirely and behaved completely normally. So the whole experiment really came down to one simple but huge question. The answer? Not a single one was identified as a fake by the hospital staff. This result was, well, it was stunning. It sent absolute shockwaves through the world of psychology and forced a really difficult and necessary conversation about how we diagnose mental illness. Rosenhan published all of this in a now famous paper called On Being Sane in Insane Places. And what it showed was just mind-blowing. It revealed how easy it was to get into a mental institution, and you guessed it, how incredibly hard it was to get back out. Okay, so let's break down exactly what happened, because the details are just wild. The pseudo-patient said they were hearing voices, really vague words like thud, empty, or hollow, and that was it. That was enough to get every single one of them admitted. But once inside, they acted totally normal. The problem was their normal behaviors were often seen through the lens of their diagnosis. They were interpreted as symptoms. They were even forced to take medication, which they had to secretly spit out. And when they were finally discharged, they weren't called sane. Nope. They were diagnosed with paranoid schizophrenia in remission. And the consequences here were no joke. Think about this. The average stay was 19 days. One person was stuck in there for 52 days. That's almost 2 months. Rosenhan's biggest criticism was that the system seemed to see mental illness not as something you could recover from, but as this irreversible treat. The label just stuck no matter what they did.
But hold on, because the experiment wasn't even over. There's a part 2, and it might be even crazier. Rosenhan called up a teaching hospital and basically said, hey, over the next few months, I'm going to send some more fake patients your way. Your job is to spot them. So the staff went on high alert. Out of 193 new patients, they confidently flagged 41 of them as probable fakes. But here's the twist. Rosenhan sent 0, not a single one.
So what does this all mean? Rosenhan's conclusion was just devastatingly powerful. He basically argued that the diagnosis had more to do with the situation, the label, the hospital setting, the expectation, than the person's actual state of mind. And this wasn't even a brand new idea. Way back in 1887, a journalist named Nellie Bly faked her own way into an asylum to expose the horrific conditions, and she highlighted the very same problem. So the Rosenhan experiment blew the doors open on this massive question. If professionals could get it so wrong, then what even is a psychological disorder? How are we supposed to define it? This really pushed the entire field to create a more scientific, more standardized way of looking at things. All right, so after all of that, here's where we've landed today. This is the clinical definition that mental health professionals work with, and it's really built on 3 key criteria, often called the 3 Ds. So let's dig into those.
First up, you've got deviance. Now, let's be clear, this doesn't mean something is bad or wrong. It just means it's different from what's considered typical in a specific culture. Next, the pattern has to be distressful. This is pretty straightforward. It has to cause real pain and suffering to the person or to those around them. And finally, it has to be dysfunctional, meaning it gets in the way of their ability to live their life, to work, to have relationships, the whole shebang. And here's the really important part. It has to meet all 3 of these criteria to be classified as a disorder. So alongside a clearer definition, our whole way of thinking about what causes these disorders has also evolved in a huge way. We've moved from seeing it simply as a sickness to understanding it as part of a much bigger, more complex system. For a really long time, the medical model was king. It got a huge boost when doctors figured out that a physical illness, like advanced syphilis, could actually cause severe mental symptoms. So this model frames mental illness as a disease with physical roots. But today, most psychologists use the biopsychosocial approach. It's a bit of a mouthful, but the idea is powerful. It says, yes, biology matters, but it's not the whole story. You also have to look at psychological factors like stress, trauma, our thought patterns, and social cultural influences like our family and society.
It helps us see that depression, for example, isn't just a chemical imbalance, but this complex web of our genes, our personal history, and our environment all interacting together.
But, having these great models is one thing. To actually use them consistently, clinicians all needed to be speaking the same language. They needed a standardized tool to make sure everyone was classifying and diagnosing disorders in the same way. And that tool is the DSM. That stands for the Diagnostic and Statistical Manual of Mental Disorders. It's published by the American Psychiatric Association, and it's pretty much the go-to guide for clinicians, insurance companies, even the legal system. Right now, we're on the 5th edition, the DSM-5. Now, the most important thing to get about the DSM is that it is not set in stone. It's designed to be a work in progress, a living document. It evolves. I mean, look at 1973. After years of activism and research, homosexuality was removed as a disorder. That was a monumental shift, a recognition that a person's identity is not a disease. More recently, childhood bipolar disorder got a new name to help prevent kids from being overdiagnosed and overmedicated. And today, experts are exploring things like internet gaming disorder, which just shows you it's always trying to keep up with our changing world. And this brings us right back to where we started. The DSM is an incredibly useful tool, no doubt. But those big, thorny questions that the Rosenhan experiment raised, yeah, they haven't gone away. The power of a diagnostic label is still something we talk about a lot. The worries you hear today sound an awful lot like what Rosenhan was getting at. Could a standardized manual lead to misdiagnosis or boxing people in? Does giving someone a label expose them to stigma and change how other people see them? And maybe the most important question of all, how do we make sure a diagnosis is seen as a description of a condition and not the definition of a person? When you look at this whole story, from Rosenhan to the DSM today, one thing becomes crystal clear. The words we use, the definitions we create, they have immense power. They have the power to shape perception, treatment, and people's entire lives.
So we're left with this fundamental tension, right? A diagnosis can be the absolute key that unlocks the door to treatment, understanding, and support. But it also carries the risk of becoming a box that's hard to escape. And that's a question the field of psychology, and really all of us, are still grappling with today.